Hello, this is Dominique, and I'll be discussing my capstone, which I labeled as contact precautions. And it is based on Massachusetts General Hospital's infection control policy. And here it goes. So, Massachusetts General Hospital was founded in 1811, and it was primarily used as Harvard's Medical School teaching hospital in Boston. So, as they performed cutting edge research from laboratory investigations and clinical trials, it had established a commitment to providing great care within their community. And once you see the numbers here at being 1.5 million outpatient visits in 2011 alone, and 42,250 inpatients treated at that hospital, you can tell that it is utilized a lot within the Boston area. Um, and that's with only 950 inpatient beds as well. So the case spawned in 2012 when MGH decided to adopt a new infection control policy that would screen all patients who had previously been flagged with MRSA, which is a healthcare associated infection. So typically it's an infection that one gets with being in a hospital or some type of clinical setting, and it's spread that way. And MRSA is very important to know about because in some cases or instances, if someone developed MRSA who has not have had MRSA and it's developed once someone has been treated in a hospital, some cases insurance will not cover the treatment costs for that. And once a infection is established, it's hard to treat it because it is resistant to antibiotics. So there are special antibiotics that is established to contain it. So the new screening process at MGH promised to improve operational performance, patient safety, and profitability with reducing MRSA. In order for the new policy to be successful, it required coordination between different departments such as admissions, the emergency department, and the IC unit, which is the unit who flags those and who've had MRSA or colonized with MRSA, and those who is actually the one who's trying to roll out this program or this process. The first rollout of the process or the pilot program failed, and it wasn't because it didn't work, it was because it wasn't being used. The emergency department did fail to use it because they had more critical things that needed to be done in the emergency department than to pay attention to creating a new screening or processing a new screening, which the PCR screening is not like any other MRSA screening, which takes like 48 hours of 3 different cultures. This one was fast. You get results within 5 hours. However, it still wasn't being utilized because it didn't fit a part of the process. The key problems that I noticed was admissions, bed availability, infection control screening process, as far as when to discontinue contact precautions, and the emergency department workflow. These are all in relation to why the precautions or why the process did not succeed. Out of the 950 inpatient beds, this is what bed availability, because again, it all coincides and works together. That's why admissions are involved in this and need to be in correlation with care with the other different departments. But out of the 950 inpatient beds that MGH has, 45 to 50 of them are always considered closed. And these could be due to any type of precaution, infection precaution. It could be influenza. It can be, as serious as smallpox or Ebola, which is something that, we've all heard about this year and the last year, as those are certain wards or certain rooms that need to be closed and readily available in case something like that is established or does happen within the community. There needs to be a number of rooms available. Also, they're used for people who are under surveillance, such as law enforcement or witness protection. So if they need to be in the hospital, they need to have a place, a bed, a private room that they can be in to be under surveillance. So there is a low number, a low percentage of private rooms, and a high number of semi-private rooms for inpatient beds. So the number of beds isn't the problem. It's how those beds are being occupied and utilized is what the problem is. And the criteria for sharing those high percentages of beds, the semi-private shared rooms, is that they have to be of same gender, of course, service type, and acuity level, which all makes sense. You don't want to put someone in a room with someone who doesn't have contact precautions or some type of standard precautions going on, as opposed to someone who does. You can cross contaminate, and it just won't be a good thing. The room turnaround is an issue with bed availability because it takes over an hour, if not an hour, to get those rooms clean and ready for someone else to use. That to me is unacceptable, and that's too long, especially with a popular hospital like this that is utilized so much. Inpatient beds must be managed in a manner to promote efficient utilization. So the inpatient bed number, the tangible number of beds, is not that big of an issue. There is enough beds, but at any given time, because there are two beds in a room, that second bed in that room could be off limits because someone is under contact precautions. And if there's a way that we can alleviate or eliminate those people who don't necessarily need to be under contact precautions, can free up space. So a solution to that is to monitor and to find out better ways to utilize those beds that's efficient and effective. And that's even with getting people out of the hospital, discharging people, having different discharge times. This is all about creating maps and value maps and flows. Infection control committee that is overseen by management, who will conduct monthly meetings to establish expectations and assure the process are still working. This needs to happen. You can't implement a process without anyone following up on it. There was a lot of alternatives that came with this case that I recognized. I didn't develop all of them in my paper, which one of them was outsourcing housekeeping. I didn't fully develop that one in my paper, nor did I even mention it because it grew too big. Costs, it can reduce costs, although they have their budget allowed for them to spend $250,000 on the new screening equipment for patients. So costs, I'm not going to say cost isn't a factor. It definitely is, and anywhere we can cut costs is always a great suggestion or a great alternative. However, I'm not sure if the cleaning staff needs to be necessarily outsourced, or they need to be trained to be more efficient. And again, they need to develop some type of process to cut down their time frame. However, cohort nurses, it's always a good idea to have as least amount of interaction with different hospital personnel as possible. And this can contain those who are under contact precautions to keep them within the same contact with the same staff. And also having that staff member potentially spread it to someone who's not under those certain contact precautions. Creating a unified patient flow. This is going to be the biggest one that I probably horn in on, because it seems as though the patient flow is a little skewed, and which is deterring patients from being placed in the correct beds and having the correct care in a timely manner from the ED or from being in a hospital transfer, just getting in a bed. And again, implementation teams, it goes back to having those committees who are responsible for making sure that the processes are followed through. Of course, assessments um, of the alternatives. I did want to point out too, with the precautions and infection control um, procedures, and that could be that people are just simply failing to practice standard procedures. If people aren't utilizing the proper hand hygiene, then it doesn't matter what processes are in place, they're going to fail. Um, and isolation definitely sounds like a good idea. However, it can create a bad experience for patients, and it can also create costs for patients because the reduced bedside visits from physicians and nurses. It can make their stay longer because of the amount of time they're being treated or checked on, and the contact precautions that they're having are going to be limited, which can create more days in the hospital, which can, cause more bills, as well as, their visitation. I mean, in certain cases where there's precautions under place for isolation due to infection, sometimes people can't come and visit them. People who are sick can't come, children can't come. And if you're a mother and you're, with children and they're not able to see you for a few days because you're under these contact precautions or isolation, it can create a very bad experience. Next is implementing a process. Again, I just discussed the mapping out the flow. So establishing a process that will take place to ensure that the emergency department is doing the screening. It's not an option not to do the screening. However, if it doesn't fit in their flow process, then it's not going to be done. So there needs to be some process mapping going on, some value stream mapping to see where there can be waste eliminated in order to have this screening in place, because it needs to be in place. It's just it's not in the right spot, so it's being overlooked and it's not being taken seriously. As well as measurement. How are we going to see if this is working out? We need to, again, establish time. How long is it going to take for this to be done and completed, and from a patient being coming through the emergency department to get in a bed, who's under precautions or who's not under precautions? Regardless of the case, it needs to be done to see if they still need to have these precautions or not. So it all matters. As well as the course of action. Again, in my capstone, I discussed the lean process, which again talked about waste management and eliminating steps in the patient flow that does not need to be there, and focusing on where we can put this new screening process at to where it is going to be done effectively and efficiently and all the time. So because it was just thrown onto the emergency department, it didn't have a home or a place in the step-by-step process, it didn't get done. So it has to be done. And the last thing I discussed, of course, was possible setbacks. Even with the best plan in place, such as this one, there are always potential errors or potential setbacks. And if you don't recognize those when implementing a new process, then it's not going to work as well. So you always have to make sure that you're following steps and steps to see where things are failing. One of these are just a list of a few potential setbacks, which is the lack of incentive for physicians buy-in. If physicians aren't a part of the process, aren't part of the implementation of of change, then it's going to be hard for them to accept change. So allowing a physician to be on that development board or be a part of the education for staff, then they'll probably have a better incentive to buy in and to follow these procedures or this process and to make sure it's done. Standard precaution. If hand hygiene is obsolete, then nothing else is going to work. Washing hands is one of the most important things that anyone in healthcare field can do. Even as a patient walking into a room visiting someone, a guest, washing hands, there should always be a place where someone can wash their hands. And if hand hygiene is not being, if it's not up to par, then any screening a patient isn't going to work, because the screening is not going to eliminate those who are under contact precautions. It's just going to make sure that they're placed in the correct bed, and we're able to discontinue those who don't need to be in, who no longer are colonized with MRSA, shouldn't be in with someone who is. So that's what we're trying to eliminate, to make sure that people who are no longer under those contact precautions do not be placed with someone who is still remaining under contact precautions, because all it's going to do is create a cycle, especially if hand hygiene is not there and it's not being implemented. And training is always going to be something that is ongoing. You can't train once a year for something that is ongoing and people need to be reiterated to use at all times. The cleaning process could be poor. So again, addressing housekeeping, making sure that processes are in place, and just getting everyone coordinated and cohesive with this, and making sure that engagement is still intact is the biggest thing. So to conclude, I do believe that Massachusetts General Hospital have a great screening process in place once it is rolled out. It's just that with the ED department, with the ED, they needed to have discussed and coordinated care with everyone to make sure that they had the screening process in the correct spot. Because if it's out of place and it doesn't feel right, it's going to be overlooked. And again, like they said, there are a lot of critical things that happen, but establishing a workflow that is efficient and effective is going to be the most important thing for this pilot PCR screening to roll out. Have a great day. Thank you.